Thank you, Kwan and Rupesh, for giving me the opportunity. So the topic that I shall be talking about are what are the imaging biomarkers which could give you a clue that you have done imaging and what you are dealing with could be a possibly infective pathology. So let's start with the vitreous. Now, as this arrowhead indicates, you could have the precipitates, inflammatory precipitates suggest sitting on the surface of the retina. So if you have these deposits, think of infection as a possible cause. So they may be on the retinal surface or posterior hyaloid, and you see them commonly in toxo, sometimes in herpes and syphilis. Now, are there any specific biomarkers between toxoviral and syphilis? Well, this is what toxo pre-retinal precipitates would look like. You will have these oval deposits on the surface of the retina, or you may have these round deposits on the posterior hyaloid, and you may see the mirror imaging. Like there are deposits on the hyaloid on the surface, they are kind of as if they are getting reflected. And you may have retrohyaloid hyperreflective dots. If you see any one of these, think of toxo as a possible etiology and then look at the choroid. Is the choroid involved underlying? For example, this is a patient which has the retinal involvement, but there is underlying involvement of the choroid, which is kind of a very strong biomarker that what you are dealing with is toxoretinochoroiditis. When we talk of viral, here when you look at the posterior hyaloid, it appears thickened. There are some hyperreflective tracts like you see with these arrows, but you do not see the round deposits like you were seeing in toxo. Now I would have gone back to show you the round deposits of toxo, which are very different from the thickened hyaloid and tracts of the viral. You may have a variable degree of vitritis, which is seen in majority of the viral, but you will not have any choroidal involvement. So that will help you differentiate toxo from viral. You can see here, there is no underlying or very minimal choroidal involvement. You don't see like in toxo. So the top represents OCT in toxo, which has pre-retinal deposits, retinal involvement, and underlying involvement of the choroid. Whereas the bottom is retinitis of viral. You do have lots of cells, but the choroid is relatively normal because viral is retinitis, toxo is retinochoroiditis. Then we come to another masquerader, which is syphilis. Syphilis, sometimes, when you look at the patient has scotoma, but, you may just pass it off as normal. Never ignore the patient. He does have scotoma. And here is the autofluorescence. Autofluorescence beautifully shows this whole area of placoid involvement of syphilis, which sometimes may be too subtle to be picked up even on clinical exam. OCT is very important. The multiple pre-retinal dots, which you may see here, RPE irregularities and the loss of ellipsoid zone. For that, it's very important that you do OCT over the lesion, not OCT through the macula, which most of the techs do. So take the OCT through the lesion, and if you see the loss of ellipsoid zone and RPE irregularities, it has a very high diagnostic predictive value for syphilis. So syphilis test sometimes could be false negative, but if your imaging is indicating, it's important to repeat them and do both treponemal and non-treponemal test. So this is the presence of, again, you can see these lesions, loss of, you can see here the ellipsoid zone, it just gets lost, and the RPE irregularities. This is something you will see in syphilis. This patient had both the test positive and was also HIV positive. So The third sign which should not be missed, which is very typical for uh, infective, is the rain cloud sign. So you have to remember that howsoever severe retinochoroiditis may be, it will have the overlying cells, but you will not see the cells bursting out of the retina. For example, this patient, you see, this is actually coming out of the retina, this is endophthalmitis. So if you see this kind of a rain cloud sign, be very, certain that it's going to be infective, and this is not one of the non-infective uveitis, and it's important because then you don't give steroids, then you try to find out the cause. We work in uveitis, and we all know that we are kind of strange people who confuse lymphomas with toxos and viral, and we all have done it at some stage or other in our lives. So are there early biomarkers? Yes. So this is kind of a diffuse picture. You can see it could happen in quite a few of cases, but this particular patient had lymphoma. So if you get the OCT through this and you see the rounded roof configuration like the arrowheads are indicating, or you see hyperreflective disorganization of the layer, and most importantly associated with subretinal or sub-RPE infiltrates. This is very highly important biomarker for a possible malignancy, because sub-RPE infiltrates are something which lymphoma very classically produces. This is another example to show you the rounded roof configuration, disorganization of the layer. So these are the biomarkers which I already kind of showed. Dengue, then we move on to the inner retina signs, and when we are in the inner retina, besides the infiltration, you could also have foveolitis, and this foveolitis here is different than what I showed on the rain cloud. Rain cloud is bursting into the vitreous, you think of endophthalmitis. When just fovea is elevated, this is foveolitis, which you could see in dengue or other post-fever viral retinitis. So we have published this, which I'm not going to, but these are the kind of the patients who respond to steroids with the restoration to normal. Another important sign, and this is very important, is ILM drape sign. This is an 11-year-old boy who comes with decreased vision in both the eyes, and which is reduced to counting fingers, and very rapid onset, and it's a very dramatic. So when you see here, there is loss of retinal layers and ILM seem to be draping over it. If you have the whole of the retina lost and only ILM is preserved, think of measles virus as a possible etiology. Moving on to choroid, you look at the granulomas all the time. So if you have the granuloma which is large, which is single, which is yellow, and which has these blood vessels running over it, think of TB. TB is VEGF driven, so the granulomas tend to have some retinal hemorrhages, RAP, or other new vascularization on top of them. So sarcoid granulomas are very different, and they can be distinguished on imaging. The top here is TB granuloma, a large single yellow granuloma with hemorrhages on the surface. And when you do OCT through the granuloma, there are changes in the outer retina. The sarcoid granuloma at the bottom, there are multiple, discrete, small, no overlying hemorrhages, and they are mostly located in the stroma. So when you do OCT, you see these granulomas like this, not like jutting out like TB. So to conclude, imaging biomarkers are important for infectious uveitis because they may give you a clue towards possible etiology, and you may investigate in a specific direction. For example, if you think it's toxo, you may or may not do anything, but you would treat. Same is for viral. But if you are thinking of endogenous endophthalmitis, you would rather do vitrectomy, or if it's pointing towards lymphoma, you will not do TB test for that patient. You would straight away go for vitrectomy because you want to rule out or rule in lymphoma. So what is most important to me is to get the OCT done through the lesion. So whenever you find an active lesion, whether it is retinitis or choroiditis, the maximum information will come when you have the OCT line scan through the lesion and correlate it with multimodal images. That's very important. Thank you very much once again for giving me.